So what have I got in today's video? This is what I call the threes in diabetes, and it's actually quite useful to think about it in this way on the wards and stack all the criteria and things that you'll be applying on your patients in the ward setting. Right, so the first slide will be a refresher and it will be something not new to you. So you think about macrovascular, you'll remember the three major complications would be ischemic heart disease, peripheral arterial disease, as well as strokes. The microvascular complications you look for and screen in all patients, and this would be then peripheral neuropathy, nephropathy, and retinopathy. Right, so moving on with that, I have another section here because there are often more than that to diabetic complications. So I'll just sort of use my top three in other, and you can change this as well. But autonomic neuropathy is an important one. Dermatological manifestation, which includes, interestingly enough, the top three is skin tags, acanthosis nigricans, as well as onychomycosis. Then you also have myopathy, which may not be that obvious, but if you look for it, you'll find it. So in other words, a patient that appears unfit, but actually may have reduced muscle strength due to myopathy. Right, so a nice three sets of chronic complications and three in each compartment. So let's go on. The deadly triad, so what's that all about in lipids? So this is LDL is dense as opposed to being large and white. So LDL in diabetics tend to be small, and this equates to dense and makes it more prone to atherosclerosis. HDL is low, which is then not protective, and then triglycerides are elevated, as you'll know. So this is known as the deadly triad. Now let's get to other things which is of almost more relevance to a hospital working doctor. Acute metabolic complications. So there are three: DKA, HHS, and hypoglycemia. So what are the criteria for each of these? So this is where things are important. So what would be the criteria for hypoglycemia? Did you know that there is more than one? So the first one is the glucose less than 3. Starting to see the trend here. Right, so the next one would be the symptom complex and signs complex of hypoglycemia. In other words, a depressed level of consciousness or neuroglycopenia, as well as then signs of autonomic overactivity. This is now the sympathetic nervous system, so think about adrenaline, and this includes being tachycardic, peripheries are cold, patient is clammy, and there's the whole host of adrenergic response involved. And then this responds to a restoration of your serum glucose. So this is known as Whipple's triad. So it's a very formal set of criteria, and it's important. You do want to see that reversibility, because if the patient doesn't respond reasonably quickly, now we're talking about 5 to 10 minutes, you should start looking for other causes for an altered level of consciousness. Right, so moving on to DKA, thinking about what are the criteria for a DKA? How do I know for certain this is a DKA? So the pH is less than 7.3. The bicarbonate will also be low with that. The glucose is often more than 30, but remember, euglycemic DKA allows for this definition to be the reverse. In other words, it's in the normal range. And then ketones, serum ketones now being the favored one, is more than 0.3. For all three of these, there are various cutoffs and various criteria, but this would be the main gist of it. Right, so let's have a look then at HHS. So there are multiple criteria for HHS, but the core of those criteria are usually these patients are not acidotic, like in DKA. Sometimes they can be due to severe dehydration and a lactic acidosis, which resolves quickly on hydration. But the pH, by and large, is 7.3, very close to it. The glucose is remarkably high, so more than 33. And that is also relative. I mean, you're not going to call it not an HHS if the glucose is a 29 or a 30. That is close enough. The serum osmol is very high, 330, or very close to that, 320, remembering that the upper limit of normal is close to 300. So 320 is getting up there. And that pretty much would be your criteria. So thinking of that, then DKA 7.3, glucose 1.3, ketones of more than 0.3, and thinking of HHS. So these are your criteria. The two can overlap, and you just call that a hyperosmolar DKA. How do you treat a DKA and HHS? The three major components here are intravenous fluids, exclamation mark, because this is the mainstay of treatment at the beginning, and this is what's going to save your patient's life. Thereafter, insulin and electrolyte management, K being important. And probably what I could have done there is made the K the second most important thing, because you do not want to be giving insulin if the patient has a hypokalemia. But what I'll do is create a separate video for the management of a DKA in a bit more detail. So look out for that one the next week or two, as well as a guideline which I will attach to that video. All right, all the best. See you next time.